You go in for a major surgery, and you think the biggest challenge is the operation itself. But what if it isn't? What if the real risk, this strange, disorienting shadow, only appears after you wake up, long after the anesthetic has worn off?
Today, we are diving deep into a really common but still poorly understood complication. We're talking about the mystery of postoperative delirium.
So, what exactly is postoperative delirium, or POD for short? Well, it's way more than just feeling groggy after an operation. It's a really sudden state of confusion, where a person's attention, their awareness, and their thinking can change dramatically, and it can fluctuate, hour by hour. It most often hits older patients in the first few days after surgery.
And the reason this is such a huge deal, why it's a public health priority, is because the consequences are just so severe. We're not talking about a temporary bit of confusion. The data is clear. POD is a major warning sign for some really serious outcomes. It's tied to long-term cognitive decline, it makes physical recovery much harder, it leads to longer and more expensive hospital stays, and it's even associated with a higher risk of death. The stakes are just incredibly high.
So this stark reality kicked off a decades-long scientific quest. In the logic, it seems so simple, right? Perfectly captured by this thought from researchers. The goal was to find a drug, a kind of pharmacological shield that you could give to a patient during surgery to protect their vulnerable brain from all that stress.
The first place they looked, the first logical candidate, was a drug called haloperidol. It's a classic antipsychotic, and it's used all the time to manage the symptoms of delirium once it's started. So the thinking was, hey, what if we give it proactively? Can we prevent the delirium from ever taking hold in the first place?
But when researchers put that idea to the test in a big trial back in 2005, the results were a huge surprise. There was no significant difference in the incidence. That's the rate at which delirium actually happened. That shield, it just didn't seem to work. The drug didn't stop it.
All right, so back to the drawing board. Scientists moved on. The next hope was ketamine. Now, ketamine is a powerful anesthetic that can reduce pain and, this is key, reduce the need for opioids, which are a known risk factor for delirium. A few smaller studies even hinted that this might be the answer.
But then came the huge, multi-center podcast trial in 2017. And the verdict? Well, it was the same story. A single dose of ketamine during surgery made absolutely no difference in the rate of delirium. In fact, it actually came with more hallucinations and nightmares after the surgery. So, another dead end.
This string of failures led to a totally different approach. Maybe the problem wasn't about finding the right drug to add, but about using too much of the drugs we were already using. Some studies had noticed that really deep anesthesia, something you can see on a brain monitor, an EEG, was linked to a higher risk of delirium. So the new question was, could we prevent it by just using less anesthesia?
Two massive trials, Engages in 2019 and a follow-up in 2024, tested this exact idea. And this is where it gets really fascinating. The anesthesiologists succeeded at their goal. They used the EEG monitors, and they gave significantly less anesthetic. And yet, it still made no difference whatsoever to the rate of delirium. This brought researchers to what seemed like the ultimate, most logical solution. If general anesthesia itself might be the problem, well, what if you just skip it entirely? For some surgeries, like fixing a hip fracture, you can use spinal anesthesia, which just numbs the patient from the waist down while they stay more or less awake.
Yet again, two large, really well-designed trials, Regain and Raga, put this to the test. And the result, by now, probably sounds familiar. No difference. No difference at all in delirium rates between the spinal anesthesia group and the general anesthesia group. A very clear pattern was emerging.
So after so many negative results, it's pretty easy to ask, was all of this research, all of this time and money and effort, was it a complete failure? Did we learn absolutely nothing? Well, not exactly. The answer is actually a lot more nuanced and frankly, a lot more interesting than that.
Let's rewind for a second, back to that very first haloperidol trial. Remember how it didn't change the incidence of delirium? Well, while that was true, it had a huge impact on what you see on the right side of this slide. For patients who got the drug, their delirium was way less severe and dramatically shorter. We're talking an average of 5 days versus nearly 12. So the crucial point is, it didn't prevent the fire from starting, but it made that fire much, much smaller and easier to put out.
And that wasn't the only clue hiding in the data. Another one started to emerge, and this one suggested that when it comes to protecting the brain, it's not just about what drug you use, it's about when you use it. Timing, it turns out, might be everything.
And this right here perfectly illustrates that point. The drug is called dexmedetomidine, and when multiple trials gave it during surgery, they found it had no effect on delirium. But another big trial looked at giving a low dose after surgery to patients who were in the ICU, and the results? They were completely different.
And this bar chart shows you just how different. Look at this. In the group that got a placebo, almost a quarter of high-risk patients, 23%, developed delirium. But in the group that got that low dose of dexmedetomidine overnight after their surgery, that number plummeted to just 9%. This was a massive breakthrough in prevention, and the key was that it happened entirely in the postoperative period.
So what does all of this tell us? Well, these decades of research have basically reshaped our entire approach. First, that hunt for a single magic bullet you can give during the operation, that seems to be over. Second, the focus is shifting. Instead of trying to prevent every single case, the goal now is to manage the impact, make it less severe, make it shorter, just like we saw with haloperidol. And third, it's become crystal clear that the real battle against delirium is won or lost in that postoperative window, in the ICU and on the hospital ward. And let's just remember why this fight is so incredibly important. This isn't just about a few confusing days in a hospital bed. As the research shows again and again, an episode of postoperative delirium can cast a very, very long shadow. It is strongly associated with a faster path toward long-term cognitive decline and even dementia.
So, we are left with this crucial, forward-looking question. That simple idea of a single protective shield, well, it's been replaced by a much more complex reality. If there is no magic bullet to be found in the operating room, it means the real challenge starts the moment the patient wakes up. And the question becomes, how must we, as patients, as families, as doctors and nurses, work together to protect the aging brain in that incredibly vulnerable time after surgery?